So I think we can start the session now. Now I have collected few questions and then I have categorized them as per the chapters. So starting with the endocrinology section first, and there was a question like it was about okay, Grisha, thank you. So it was about primary hypothyroidism, right? So it was about primary hypothyroidism. Now, to understand the concept of the thyroid function, you have to understand the hypothalamic pituitary and the thyroid axis, right? So on the top is hypothalamus, second to that is anterior pituitary, and lower down is the thyroid gland. Okay, so hypothalamus secretes TRH, right? So it secretes TRH, and this TRH actually controls anterior pituitary. So this TRH will stimulate, or it will promote the anterior pituitary to secrete TSH. Now this TSH is promoting, or it will be stimulating the release of the thyroid hormones from the thyroid gland, namely T4 and T3, right? So the usual axis is that TRH from hypothalamus, clear? Now it will give command to anterior pituitary, from where there will be release of TSH, right? So TSH is from anterior pituitary, and this TSH will promote release of T3 and T4 from thyroid gland. Clear? So this is the usual axis. Now what will happen, there might, like in cases of the hypothyroidism, when we say hypothyroidism, we mean that there is less of thyroid hormones. So there is less value of T3 and T4. So suppose if we say hypothyroidism, it means decreased T3, decreased T4. Clear? So that is hypothyroidism. Now there are different words: primary, secondary, or tertiary. So primary means when there is pathology in the thyroid gland itself, right? So if there is pathology in the thyroid gland, and this what is responsible for low levels of T3, T4, that is known as primary hypothyroidism, right? So whenever we are using the word primary, it means the problem is in the thyroid gland itself. So this is the primary hypothyroidism. Clear? Now suppose thyroid is working perfectly, but there is some problem in the anterior pituitary, then this will be known as secondary hypothyroidism. Clear? So low levels of T3, T4 are because of low levels of TSH. Fine? So that is secondary. Now there is possibility that thyroid and anterior pituitary both might be right, and there is problem in the hypothalamus. So in that case, this will be tertiary, right? But we are more interested in discussing the primary part and the secondary type of hypothyroidism, right? So in primary, these will be less, right? Now what will happen? This will send a command backward, and this is like this. Okay, so it will send a command backward, and it will tell to increase the level of TSH, right, or TRH. So in primary hypothyroidism, what will happen, that there will be low levels of, so if we talk about primary hypothyroidism, and if in the other columns we can write T3, T4, and here TSH. So what is happening in primary hypothyroidism? See, in hypothyroidism, T3, T4 will always be less, right? So whether you take primary hypothyroidism or whether you take secondary hypothyroidism, Clear? So here this is again going to be less. This is same for both the varieties, but what actually helps us in differentiating is the level of TSH, right? So in primary hypothyroidism, what is happening? There is a positive feedback, and that will order the anterior pituitary to increase the amount of TSH release. So in primary, TSH levels will be high. Now coming to secondary. Now we discussed that in secondary type of hypothyroidism, there is pathology in the anterior pituitary itself. So what is happening in secondary? In secondary, the TSH levels are less, and consequent to that, the T3 and T4 levels are less, right? So here what we will see like this. So in secondary, this just because of this low level of TSH, there is low level of T3, T4. But in primary, what is happening? Thyroid gland is not working properly, so the T3, T4 levels are less, and this leads to an increase in TSH, right? So this is how, if you remember this simple equation, I think you will never be wrong in your diagnosis of primary hypothyroidism. Primary means the thyroid itself is releasing less of hormone. There is no fault of anterior pituitary, or there is no fault of hypothalamus, right? So this is primary. Secondary hypothyroidism means thyroid is working properly, and this low activity of thyroid is secondary to pathology of anterior pituitary, which is sending the stimulating hormones less in amount. So less hormone will come, obviously the thyroid will function less. So this is the concept of primary hypothyroidism and secondary hypothyroidism, and it is quite easy if you know the basic physiological concept. Clear? So this was one question. Now we move on to second question, and this was more of pharmacology rather than pure medicine part. So a patient of diabetes mellitus, he was on some anti-diabetic medication and he developed hypoglycemia. Now which anti-diabetic drug he was taking, right? So we have to identify that. Now there is a simpler way of understanding this question. See, if we are saying hypoglycemia, right? So if we are saying hypoglycemia, it means what is happening to blood sugar levels? It means there is decrease in blood sugar levels, right? Now this decrease in blood sugar level can be brought about by, I think everyone can answer, which hormone act to decrease blood sugar level? This is insulin, right? So insulin, it acts in a manner so as to reduce down the blood sugar level, right? So therefore, any drug which will promote release of insulin might cause hypoglycemia. So that is the basic concept behind this particular MCQ, right? So if you remember this point, like the drug which will promote release of insulin is bound to cause hypoglycemia, because the effect of insulin is to decrease blood sugar level, right? So, and those drugs are actually the gliptins. So those drugs are actually gliptins, and these gliptins, they promote release of insulin, right? And they decrease glucagon. So when I say they promote the release of insulin, what they are going to do? They are going to decrease the blood glucose level, and that is what is hypoglycemia. Clear? So with that particular concept, I think you can remember gliptins. The gliptins, they promote release of insulin, and insulin will cause hypoglycemia, right? So that way I think you can associate the concept with this particular MCQ. So remember gliptins as a cause of hypoglycemia, as they increase insulin level and the decrease glucagon level, resulting finally in low blood glucose levels, right? So this is the basic concept for this particular MCQ. Now moving to another question from the diabetes, and I think this is one common question which has been asked numerous number of time, and you can say it's just a kind of repeat, you can say like that. So long-term glucose control, I think most of you can answer this. What will be the answer to this question? Long-term glucose control, it can be assessed by, yes, you can answer. Anyone? Long-term glucose control. I think it's not that difficult. So the answer is glycosylated hemoglobin, HbA1c. Okay, so that is glycosylated hemoglobin, and I think most of you must you can recall that glycosylated hemoglobin is like is a useful tool to assess the blood glucose levels in the past 3 months, and there is one more, that is serum fructosamine, that is used to monitor the levels in the previous 3 weeks, right? So we have 2 important tools here, but if the question is about long term, then obviously you will go for glycosylated hemoglobin, right? So HbA1c, that gives a rough assessment of the blood sugar control or levels in past 3 months. Clear? So this is 3 months, and then there is another serum fructosamine. This is blood sugar in past 3 weeks. Clear? So fructosamine for 3 weeks, glycosylated hemoglobin for 3 months, and fructosamine is very important in cases of pregnancy, because in pregnancy we have to keep a very sharp eye on the level of blood sugars, because you must have read in obstetrics that if there is maternal diabetes, that can affect the fetus and of course the mother as well, right? So Kushagra bhai, namaskar, thank you bache, right? So serum fructosamine is especially checked in pregnancy, because we have to check the blood sugar levels in a very short span of time, that is usually 3 weeks. But otherwise in general population we prefer glycosylated hemoglobin, which tells us about the blood sugar levels or average blood sugar levels in the past 3 months, and this is somewhat related to the lifespan of RBCs as well. So the 2 important things, one is fructosamine and the second is glycosylated hemoglobin. And yes, for long term glycosylated, this is for past 3 months. So this will be the answer here, right? So that gives a rough assessment about the level of control. And with HbA1c we can also have a we can just have a assessment of the average blood sugar level as well, so that also help us in that way, right? So these are 2 important tools with us to monitor the average blood sugar levels retrospectively, you can say. So for this particular answer, for this particular question, the answer is glycosylated hemoglobin. Clear? So this was a repeated question, and I think most of you must be already knowing about this. So I'm not going to discuss much right about this. Now, this is one more question, and actually this is more of anatomy, but I have kept it here because this is somewhat related to cardiology as well, and I just want to discuss some other things also in relation to this image. Now, the question was about, like, you have to identify the areas. So kindly, the nomenclature you can change. You can keep this as 1, this as 2, this as 3, and this as 4, right? So you can take the labels, you can slightly change the labels. So 1, 2, 3, 4, and then you have to identify what is the exact which option matches with the exact location of the valves. So anyone would like to answer here, or should I go with the explanation part? Yes, if someone would like to answer which one is the right answer to this particular MCQ. Otherwise, I will go with the explanation part. Anyone? See, there is no punishment for wrong answers. No problem, you can just try. Otherwise, I am there to help you out and just to clarify the concept to you, so that the concept becomes much more crystal clear to you for future. So, Krishna. Oh, wonderful, Krishna, wonderful. Yes, I'm really impressed. Yes, so Krishna is absolutely right. So 1 is aortic, 2 is pulmonary, 3 is tricuspid, and 4th is mitral, right? So these are the auscultatory areas for, yes, Kushagra, perfect, you are also correct. So these are the areas for auscultation, right? Now here you need to remember one thing: the location of the valves are different and the auscultatory areas are different, right? So please remember this is a very important concept, because many times students, they think that location of valve is the site of auscultation. It is not like that. Location of valves is different from areas of auscultation. Clear? So please remember. Now what I am going to discuss here is the area of auscultation, where you should keep the diaphragm of your stethoscope if you want to hear the sounds related to that particular valve. So 1 is, of course, aortic. Yes, this is aortic, this is pulmonary, this is tricuspid, and this is mitral. Clear? So nomenclature is okay. Now you can see only the aortic area is on the right side, and all the 3, pulmonary, tricuspid, and mitral, they are on the left sides, right? So just notice this. This is the left side, clear? And this is the right side. Okay, so pulmonary, tricuspid, and mitral are on the left side, and aortic valve auscultatory area is on the right side. Okay, this is one thing. Now I just want to discuss something more. Now look at the location. Now we should know the location as well. Now how you will realize the location? This is the second rib. Okay, so this is the second rib, and below the second rib is second intercostal space. So this is the second intercostal space. Clear? So again, this is the second intercostal space, right? So this is the second rib, this is the third rib, This is the fourth rib. Okay, so here this is the second rib, this is the third rib, right? And in between the two ribs we have the intercostal space, right? So this is the second intercostal space. Here this is the second intercostal space, right? And then lower down this is third intercostal, right? So this is third intercostal space, and then even lower down this is fourth intercostal space, and lower down we have the fifth intercostal space, right? So this is fifth intercostal space. Clear? Now what you can see here, now we can also mark the limit of the sternum. So if you say this is, you can just, this is sternum you say, right? So the aortic, if you look at the aortic auscultatory area, it is in the right second intercostal space, just lateral to the sternal margin. Okay, now if you come to the pulmonary, the location is same but on other side. So it is left second intercostal space, right? So B is pulmonary and A is aortic. Now C is the tricuspid, and tricuspid is usually in the fifth intercostal space, although it is showing somewhere in the fourth in this image, but it is usually in the fifth intercostal space, again left side, right? And just lateral to the sternum. Clear? So just lateral to the sternum in the fifth intercostal space on the left side. So this is represented by C. And now most important of all is the mitral valve, right? So mitral is in the mid clavicular line. If you draw a line from the clavicle, something like this, so this is mid clavicular line, right? From the center of the clavicle. So this is the clavicle actually, right? So this is left, of course, fifth intercostal space, mid clavicular line. Clear? So this is how you can remember the auscultatory areas. Now these are not the actual location of the valve. Again I am telling you, these are the auscultatory areas, right? So these are auscultatory areas. Although this is more of anatomy, but I just kept it over here because this is directly or indirectly related to cardiology as well, right? So this is one thing. Now I have kept one image just to help you out. So in this image I have shown you both the auscultatory areas and as well as the location of the valves. And I just want to focus and I just want you to remember that what is the actual location of the auscultatory areas and how they differ from the location of valves, right? So since we have already discussed the auscultatory areas, so firstly we will take up the auscultatory areas, right? So firstly I will take up the aortic valve auscultatory area, sorry. So this is the aortic, okay? Right second intercostal space, just lateral to the sternal margin or sternum, right? So this is aortic area, I think, right? So this is aortic. Clear? Now aortic is on the right side, second intercostal space. Which area is on the left side, second intercostal space? I think everyone can answer. This is the pulmonary area, right? So this one is the pulmonary area. Clear? So this is pulmonary area. Fine. So we are done with 2. Now we will take the tricuspid area, right? So we will take up the tricuspid area. Tricuspid area, just recall what I told you. Left fifth intercostal space, just lateral to the sternal margin. Clear? So here it is. So this is the tricuspid area. So this is the tricuspid area. Fine. And now the important of all, that is the mitral area. So mitral area, I told you that it is in the fifth intercostal space, just medial to the mid-clavicular line, right? So if you see, this dotted line is the mid-clavicular line. Okay? And this is the location of the mitral area, right? So this is, so these are all the auscultatory areas where we hear the auscultatory sounds properly, or the murmurs related to these valves properly, right? So these are auscultatory areas. Now I will show you the actual location of the anatomical valve. Now how the valve are present. So suppose if I take the aortic valve first. If I take the aortic valve first, so this is the aortic valve. So I'll take it with green. So this is the aortic valve, right? So see, aortic valve is so at a different place from the auscultatory area of aortic valve, right? So this is aortic valve. Now let us take the pulmonary valve, right? So I'm sorry. So let us take the pulmonary valve. Now this is the location of the pulmonary valve. Okay, so again you can see pulmonary area is above, pulmonary valve anatomical location is below that particular area, right? So it doesn't coincide. These are not at the same place. Now we will take the tricuspid area. So now this is the tricuspid valve location. Okay, so this is the tricuspid valve, and look at the position of the mitral valve. So this is the mitral valve. Clear? So tricuspid valve, mitral valve, almost at the same location if you just consider the anatomical position of the heart. So you can, if you look here, this all area is about the valves. Clear? So these are the locations of the anatomical valves, and see the auscultatory areas are so different, right? So this was some beautiful concept which I just want to share with all of you, that anatomical location of valve is somewhere else, and the auscultatory areas pertaining to those valves are somewhere else, right? So in clinical practice, whenever you have to do any auscultation, you should know the position of, for auscultation for aortic valve, pulmonary, tricuspid and mitral, right? So these are entirely different from what the actual location of valve is, right? So this was very beautiful concept, and I just want to discuss this with you. So that's why I kept this anatomy question here, right? So that was the only reason. Anyway, I think now the concept must be clear to all of you. Now we will jump on to a core medicine topic, and a very important one, and sometimes I regret I haven't kept this in my PYQ sessions, although it was always in my plan, but I don't know how it escaped out of my mind, and I regret this should be there. Okay, so this is one important question. And ECG, from exam point of view, you should know. From clinical practice of point of view, you should know, especially MI, right? So anyway, so we have a ECG something like this. I don't know the exact one, but this is I have taken just for discussion part. So a patient presented with chest pain, right? The moment you have this word in your MCQ, somewhat it suggests that there might be a case of myocardial infarction, right? And then ECG has been given. So once we think in that direction of myocardial infarction, right? So if we are thinking of myocardial infarction, so what is the important thing which we should keep in mind? We should always search for ST segment elevation in the ECG leads, right? So we have to search for ST segment elevation, and we will just mark out in which of the leads we can mark out ST segment elevation. So before that, you should know actually what or how ST segment elevation looks like, right? So actually, if suppose this is P wave, then this is QRS complex, this is ST segment, this is T wave. So this is the usual presentation of an ECG, right? So this is P wave, this all is QRS, and this is T. Now what will happen if I'm discussing like ST segment elevation? Now what will happen, this part will go up something like this, right? So there is an elevation of the ST segment, because this all is the ST segment. So it means the ST segment has gone above the baseline, so that is known as ST segment elevation. Now let us study this ECG and let us see where we can find the ST segment elevation. So if we look here, no ST segment elevation, no ST segment elevation, right? This is ST segment actually, this is. So here also no ST segment elevation, right? Here also we cannot see any ST segment elevation, right? Then this is here, no ST segment elevation. But if you look here properly, this part, right, you can see clearly that ST segment has gone above, and it has gone even above the QRS complex, the upper height of the QRS complex. Similarly, you can see here, right? You can classically see ST segment elevation, right? So this is the typical ST segment elevation, right? So we can see that then again in the remaining leads, there is no ST segment elevation here, there is no ST segment elevation here, right? So only in the 4 leads we can see a classical ST segment elevation, right? If you have this kind of picture in which you can see ST segment elevation in V1, V2, V3 and V4, right? So here this is V1, right? This is V2, this is V3 and this is V4. Now what will be your answer if you can see ST segment elevation in V1, V2, V3 and V4? What will be your answer? Anyone? What will be the answer if you see ST segment elevation in V1, V2, V3, V4 as we can see in this ECG? Yes, any answer? No problem. Shagar, see, I say you all can try, right? And this we can take this session as an opportunity to clarify our concepts, and we can understand like, oh, what was wrong with my concept, like. So you don't feel bad. You have all liberty to answer whatever you feel right, and I'm there to clarify the things, and I'll try to deliver the concept so that you can remember it for long, right? So anybody else who want to say something else? Anybody? Yes, Krishna. Great. So okay, let me clarify the things. Like here, if you take it in exact terms, V1 and V2 suggest septal MI. Clear? V1 and V2 suggest septal MI, but yes, if we have only V3, V4, it will be anterior MI. Clear? So V1, V2 septal MI, and if we have ST segment elevation in V3, V4, that is anterior MI. So considering this particular ECG, the exact answer would be anteroseptal MI, right? So that will be the exact answer. So this is actually anteroseptal MI. Clear? Because we are getting ST segment elevation in V1, V2, that is for septal part, V3, V4, that is for anterior part. Clear? So this is one thing. Now we have two more types, common types, like as Kushagra said, lateral wall or inferior wall, right? So for lateral wall, you have to look for ST segment elevation in 1, AVL, 5 and 6. Clear? So if you have ST segment elevation say in V1, AVL, V5 and V6, then your answer would become lateral wall MI. Clear? Or if the elevation is in 2, 3 and AVF, then your answer would become inferior wall MI, right? So what I want to teach you, or what I want to tell you, that firstly you need to identify ST segment elevation, how it looks like. Number one, you have to identify how a ST segment elevation looks like, and then you have to identify out of these 12 lead ECG, if you are pointing out ST segment elevation, then which part corresponds to which type of MI, or which part of the heart is infarcted, right? So I have told you like V1, V2 for septum, V3, V4 anterior, and then 1 AVL, V5, V6, this is lateral. Okay, so this is lateral wall MI. And if there is lead 2, lead 3 and AVF, then your answer would be inferior wall MI. So is that portion clear? So this is a very beautiful concept, and I think if you can understand it, then there is no need of cramming up the things. Just simply look at the ECG, point out the ST segment elevation, count the leads and correlate with your answer. It's very simple. The only thing is that if you get to remember this particular formula, right? So V1, V2, okay, I can just draw it once again for clarification, right? So okay, so just to help you out, right? So suppose if there is V1, V2, this is septal, right? If there is V3, V4, that is anterior, right? If there is one AVL V5 V6, then it is lateral. Okay, and if it is 2, 3 AVF, it is inferior wall MI, right? So this is how you can remember. Saichand, I'll surely take a revision class for NEET PG, don't worry. But I think for this particular week, I'll be trying to take the all subjects PYQ, so that at least the FMG part is over first and I am free from that area. Then definitely I'll go for NEET PG, don't worry. And thank for your request. I'll definitely consider that, and maybe from second half of July I'll focus on NEET PG, right? So thank you, you are here, I'm really honored. So I'm thankful to your words. Okay, so definitely I'll do that, but let me finish the FMG part first. That is the most priority thing for me, right? So I think this is how you can remember, and I have kept an image as well, so this will just simplify the things for you. Like lead 1, right? AVL V5 and V6, right? So this is all lateral wall MI. Clear? Now if I say 2, 3 and AVF, this is what? This is inferior wall. Okay, this is inferior wall MI. Now if I take 1 and 2, so if I take 1 and 2, this is septal wall or septal MI. Clear? And if I take V3, V4, then answer would be anterior wall MI. Clear? So this is anterior wall MI. Clear? So just like how you can remember it, I think you can never be wrong if you get an ECG. I'm very pretty sure if you can just revise this much, only you have to identify ST segment elevation, that how it looks. Correlation is quite easy. Just remember this picture and you'll be always right. Right? So this was really one very important question which I just love teaching actually, and I'm extremely sorry I don't know how it is skipped out of my mind, otherwise I would have definitely kept in the PYQs before the exam. Right? Anyway, no issues. Now next is again Kussmaul sign. Now Kussmaul sign, and it shouldn't be confused with the Kussmaul breathing pattern. This is Kussmaul sign, and this is related to, as you can see in the image, this is related to jugular venous pressure, right? So now what happens, the normal physiology, when you inhale, right? So when we inhale, there is a negative intrathoracic pressure, right? So there is negativity inside the thorax. So what happens, the blood in the jugular veins, it is also sucked in, right? So blood in jugular vein is sucked in, and therefore there should be a fall in JVP column. Clear? So it should ideally, normally it should go down, but what is happening in Kussmaul sign, JVP remains elevated even during inspiration. So this is the Kussmaul's sign, right? So this is the Kussmaul sign. Clear? So JVP, it should go down when we inhale because of negative intrathoracic pressure, but here it remains elevated, and it can be seen in constrictive pericarditis, restrictive pericarditis, or restrictive cardiomyopathy, or tricuspid stenosis. So any process which hampers with that descent phenomena of the blood from the jugular veins, that will lead to Kussmaul sign, right? So constrictive pericarditis is okay, restrictive cardiomyopathy is okay for examples, and tricuspid stenosis is okay. So the answer for this question comes out to be cardiac tamponade, right? So this is how you should remember, and I kept this image just to show you like what actually Kussmaul sign is and what we actually see in Kussmaul sign. So one should know what actually because theoretically we can discuss, but we should know how it looks in clinical practice, right? So this is how during inspiration the jugular pressure remains, or jugular venous channel, the blood, it remains elevated, right? So this is Kussmaul sign, and suggestive of any process which hampers with that descent of the jugular component, right, or the blood level of jugular veins. So cardiac tamponade is the better answer here. Then there was one question, and again this is a new question, and I think a little difficult for the students as well. Rescue PCI. Rescue PCI. Now PCI means percutaneous coronary intervention. Percutaneous coronary intervention, and in simpler forms you can remember it like stenting, right? So what we do, like suppose if the arteries, if the coronary artery is blocked, something like this, so what we will do, we will pass our stent and we will dilate it, right? So it will be dilated, and there is a stent, something like this. So this is a stent. Clear? So this is the stent, or you can say percutaneous coronary intervention. So rescue PCI is done when we have already tried thrombolysis, or in simpler words you can say when we have already tried all the conservative part of managing that patient, and still the patient is not showing any improvement, and it becomes very necessary now to do some intervention, and that is PCI, that is percutaneous coronary intervention, right? So if someone asks you what is this rescue PCI and when it is done, you can say that it has to be done when the conservative management, that is the thrombolysis part, has failed, it hadn't yielded the desired result, right? So I have just taken one algorithm just to show you like how the patient is approached. Like the one of the initial and the very characteristic complaint of the patient is that he will be having a chest pain with excessive sweating, then the chest pain might radiate to the inner side of the left arm, and then with the like someone putting a wire around the chest, that kind of very severe pain. So that suggests that there is a possibility of a myocardial infarction kind of pathology, right? So the patient is taken to the nearby medical center, where we start thrombolysis and antiplatelet therapy, again with aspirin or clopidogrel or oxygen, morphine for pain and all, right? And thrombolysis is done. Now it is this thrombolysis, if it fails, like then we have to go for the rescue percutaneous coronary intervention, right? So if all these conservative modalities, or you can say the drug therapies, if they fail, then finally we have to switch on to PCI, that is stenting, right? So if someone asks you what is the indication for rescue PCI, you can simply say that if there is any failure of the conservative management part, that is antiplatelet or thrombolytic therapy. Clear? So this is the image of what I am trying to show you in terms of PCI. So this is percutaneous coronary intervention. Clear? So this is the PCI thing. So what we do, we pass a guide wire and then a balloon, then finally a stent, and then the stent, when it is dilated, it is left in place, and it just makes sure that the the lumen of the blocked coronary artery has opened up sufficiently to allow flow of blood. So we can have plain stents, we can have some drug eluting stents, so that is all advanced thing. I'm not going into that, but this is what PCI is, right? So we will put a balloon catheter and then we will dilate the balloon so as to get the stent at the desired place, right? So this is PCI. Many times you must have heard of angioplasty, right? So this is the same thing what we discuss in terms of PCI. Clear? So if someone asks you what is rescue PCI, you should be able to say that if the conservative plan fails, we need to switch on to PCI, and therefore it is known as rescue PCI. Now we will go to hematology section, and here we have a question like which states that there was a lady who is having recurrent headaches, easy bruising, and there are some episodes of visual blurring. Now what was most important here is that the platelet count was increased, but the red blood cell and WBC count was absolutely normal. So there was isolated increase in the level of platelets, right? So just going with the question statement, I think most of you can think of, like, if increased platelet, this is thrombocytosis, right? So that way simply you can just switch on to the answer as essential thrombocytosis. That there's a simplest way, but we can go with the discussion part also. Like here, if you see, the WBC count is normal. Now if the WBC count is normal, you can very well exclude CML or AML or any type of leukemia, because we all know that in leukemia we have a very high WBC count. So if WBC count is normal, you can exclude CML and AML. Then if the RBC count is normal, then you can exclude polycythemia vera, because we know that in polycythemia vera there is increase in RBC count, right? So this way also we can reach up to the answer. So for many, this question might be out of the syllabus, because we usually don't teach essential thrombocytosis to students usually, but I think by this simple correlation you could have marked this answer right. So this is essential thrombocytosis, pretty clear from the case history itself. Now these like bruising or these some features, they are common in thrombocytosis and polycythemia vera, right? These symptoms might be common, but these investigations just help us to differentiate the two entities. And just to take a few more words, like essential thrombocytosis, platelets are high. In polycythemia, RBCs are high. Clear? This is one important difference. Then now if you look at the symptoms like thrombosis, hemorrhage, splenomegaly, you might find, or vasomotor symptoms, you might find the entire things same for both the conditions. Okay, Thota, Vani, Supriya, no problem. It is just like the students who have shared these questions. So I have prepared that. If that's not there in the question, not an issue. See, actually these are all recall, right? So sometimes students, they also mix up, or sometimes what students actually try to convey to us, the perception might be wrong from our side as well. So anyway, you can exclude this question, not an issue, but I thought that like we can just take an opportunity just to discuss few points about this important differential diagnosis, because clinically both the conditions presents with same features, but what is more differentiating, number one, essential thrombocytosis, we have increased platelet. Polycythemia, we have increased RBC count. And more importantly, in polycythemia, there is pruritus, especially after taking a bath. So this is a very classical clinical feature of polycythemia, right? Patient will start itching as soon as he take a bath. So this is very important clinical feature, and it might help you maybe sometime later. So please remember this, right? So I'm not going into further details. So this is just what I just want to discuss with all of you, right? Then there was one more question which has been provided, and that was about headache, right? So here a lady was having unilateral throbbing headache, and then there are certain aggravating factors like light, which usually aggravates that, right? So, and there was just another, like she skips her breakfast occasionally. Now what is important to remember here is that there is unilateral throbbing headache, right? So unilateral throbbing headache. And before answering this particular MCQ, I just want to show you a picture so that you can understand like what are the common clinical types of headache which we find in clinical practice, right? So migraine, I think all of you must have heard or you have read a lot, even in pharmacology when we take sumatriptan and all drugs, so we always go for migraine discussion also, right? So migraine is unilateral, clear, and throbbing headache. So that is very important here. And then one important thing which was also mentioned in the question is that light sensitivity. So the patient is photophobic, or you can say light sensitive. So this is very important here. And then in the tension type of headache, as the name suggests, there is some sort of tension, and usually the lady might be having some tension at home in terms of the poor performance of the kids in the school or some other family tension. So that is tension headache. And what the person feels, that there is a rope being tied across my head, right? So the patient will feel as if a rope has been tied around the head, and it will be like a squeezing kind of pain, right? So that is the word squeezing, right? So this is important here, squeezing sensation, right? So this is squeezing sensation. So this is very important for tension headache, right? And again, as the name suggests, tension, so there is some stress which is is the reason behind the headache. So tension headache. Now cluster headache is even more classical, and the name is headache, but the patient usually has the pain around the eyes, right? So there is pain around the eyes. So we call it headache, but patient will say that there is pain somewhere around the eyes, or somewhere around my eyes, or sometimes behind my eyes. So that is cluster headache. So cluster headache is also one very severe kind of headache, and typical location is this, right? So this area patient will have lot of pain. So this is cluster headache, right? So I think one should not have any confusion between tension headache, cluster headache, and of course migraine, which will be on the one side of the head or the face, right? So this is especially because of light sensitivity. So I think just getting with these words, you can easily mark out that the answer to this particular MCQ is going to be migraine. Right? Now here I'll take the opportunity and I'll discuss about the frontal sinusitis headache as well. So just few words about frontal sinusitis, because this is also an important concept in ENT actually. So frontal sinusitis headache. Okay, so what we are actually focusing here, we are discussing the headache part. Now this is also known as office headache. And why this is known as office headache? Because it shows periodicity. Now what is periodicity? Periodicity means it will start at a particular time, it will peak at a particular time, and it will go away at a particular time. So here the pain starts at around 9 a.m. right, and then it will peak around 12 noon, right, and then it will disappear by, you say, 5 p.m. right. So what is happening? Pain will start at 9 a.m., will peak by 12 noon, and then it will disappear by 5 p.m. Now if you look properly, this is the time period of actually office. So 9 a.m. to 5 p.m. are actually the office hours, right? So patient will say that I am having headache, and the office colleague or even the boss, he will think that this guy is always making excuses, he don't want to work. But that is not the case. He is really having a problem, and since the symptomatology is such, like it is corresponding to the duration of the office hours, so therefore we also call it office headache, right? So this is quite different, and for this you will have the periodicity has to be the important word here, right? And this is also known as office headache because it is present only during the office timings, not before or after that. So this is frontal sinusitis headache. Anyway, and so I think for answer, unilateral throbbing, sensitive with, especially after exposure to light, you can think of migraine, right? So that is migraine. Now next question, again a very important question, and I think it has been discussed so many number of times, even in pathology or microbiology. So meningitis with low sugar, high proteins, and elevated polymorphonuclear cells, right? So sugar is less, proteins are high, and polymorphonuclear means neutrophils. So the moment you have this kind of presentation in a case of meningitis, I think it is quite easy for you to answer bacterial meningitis, right? So and just you can say that sugar is less because it is all eaten up by bacteria. Clear? So that's why sugar is less. And in bacterial meningitis we will have neutrophils, and also if you look at the appearance, the gross appearance of CSF, how it will be? It will be turbid. Clear? So this is a classical explanation for bacterial meningitis. Fine. Now for tubercular meningitis, I think most of you must be knowing that instead of neutrophils there is increased number of lymphocytes, which are also known as mononuclear cells, right? So these are polymorphonuclear, those are mononuclear. So this is just a table just to summarize the things. Now for anything it's better you know the normal first, then only it is very clear or very easy for you to understand what actually is abnormal now, right? So if we take the normal CSF findings first, normally the CSF is clear, Okay, if you take it in a test tube, it will appear transparent or clear. Then proteins are about 15 to 40 milligram per deciliter, and sugar is about 50 to 80 milligram per deciliter. And normally we can see some lymphocytes, but the count is always less than 10. So 0 to 5 lymphocytes. So lymphocytes can be seen normally in a normal CSF sample. Now, how the thing changes in bacterial? The appearance becomes cloudy. What we have already discussed, that you can also remember, this can also be written as turbate, right? So it appears cloudy. Then proteins are elevated. You can see it can range from 60 to 1000 milligram per deciliter. Sugar 0 to 45, so less than 50. And you have mostly neutrophils, and the count can be 1000 to 50,000 milligram cells per cubic millimeter, right? So this is polymorphonuclear. Clear? So this is for bacterial. Now if we take for tubercular, we can take for tubercular first. So either it can be clear or it can show a clot, and this clot is written as cobweb appearance. I think most of you must be knowing this. So cobweb or clear. Then proteins are elevated. Yes, it can be from 45 to 300 milligram per deciliter. Then glucose is decreased, and we see increase in lymphocyte count. It can be from 10 to 1000. So this is lymphocytes. Clear? So sugar decreased, right? Now what we can see in viral meningitis, in viral the appearance is clear, proteins may be normal or increased. Similarly, glucose is also normal, but we see raised lymphocytes which can be 100 to 1000. So this is lymphocytes. So what is important for you to remember here is that sugar level is normal as compared to bacterial and tubercular, where it is reduced. So this is one important point for differentiating viral meningitis or aseptic meningitis from bacterial or tubercular meningitis. So focus on the level of sugar. If it is normal, it is not at all bacterial, less possibility of tubercular, it is more suggestive of viral. Clear? So this is very important whenever you are discussing the meningitis, right? So when you have to discuss between bacterial and tubercular, look for the type of cells. Let me summarize this, right? So cells type, it will help you to differentiate between bacterial meningitis and tubercular meningitis, right? So in bacterial you will see increased neutrophils, and in tubercular you will see increased lymphocytes. Clear? Now lymphocytes are also raised in viral meningitis. So here tubercular and viral are differentiated based on sugar levels. In tubercular, sugar level is less, and in viral it is normal, right? So this is how you can summarize the chart. And very important topic, I think almost every year, whatever exam, you will always have a question, direct, indirect, from this particular segment, right? So this is a typical analysis of CSF in a case of meningitis. Now next question. Now here a patient presented with bulbar paresis and autonomic involvement, and then most importantly there was an incremental response on repetitive nerve stimulation test. So this is repetitive nerve stimulation test. Okay. Now incremental means improvement in one sense, right? So the moment you have this incremental word, the answer which comes to your mind should be related to Eaton-Lambert syndrome, right? Because in myasthenia gravis we find a decremental response. Clear? So on repetitive nerve stimulation test, so this is decremental response. And even like whenever we are discussing symptomatology of myasthenia gravis, we discuss that as the time passes, the weakness of the muscle increases, and therefore the symptoms of the myasthenia gravis are more prominent during the evening time, and you can see ptosis or other features which are suggestive of muscle weakness, right? So with more activity, muscle weakness increases in myasthenia gravis, whereas it improves in case of Eaton-Lambert syndrome, right? So this is one important finding. Now what actually is the, now this concept is extremely important, and you should know what are the basic difference between Eaton-Lambert syndrome and myasthenia gravis. So firstly, you should know the anatomy of the neuromuscular junction first. Now this is the presynaptic, this is the postsynaptic area, right? And in between, this is all synapse, right? So this is synapse. Now myasthenia gravis is a disorder of postsynaptic area, whereas Eaton-Lambert is a pathology of presynaptic area, right? So number one, so if I write Lambert-Eaton is presynaptic and myasthenia gravis is postsynaptic. Okay, this is one in terms of their location. Now let us see what is the pathology actual in Eaton-Lambert syndrome or myasthenia gravis. Now what happens in myasthenia gravis, there are antibodies which are directed against acetylcholine receptors, right? So here we see antibodies in myasthenia gravis, right? Because this is postsynaptic part, right? So antibodies against acetylcholine receptors. But what is the pathology in Eaton-Lambert? There is affection of the voltage gated calcium channels, and this is again presynaptic part, right? So in myasthenia gravis there are antibodies against acetylcholine receptors, whereas in Lambert-Eaton syndrome there are antibodies against the calcium channels, which are actually the voltage gated calcium channels. Clear? So this is number two, area and what actual site, right? Now third, what, and extremely sorry, now the third thing which we discussed here in terms of repetitive stimulation, in Lambert-Eaton syndrome the weakness improves with contraction, right? So the weakness improve, and that is like incremental response on repetitive nerve stimulation test. Now what is happening in myasthenia gravis? The weakness worsens with muscle contraction, and therefore we see there is extreme muscle fatigue by the end of the day, because throughout the day he will use the muscles, and by the end of the day he will have muscle weakness, right? So in myasthenia gravis muscle weakens, whereas in Lambert-Eaton syndrome it improves. right? So that is what mentioned in the as an incremental or. So here you can write incremental response, and here you can write decremental response. Clear? So this is very important. Now in question, if you read here, there is one more term, autonomic involvement. Now autonomic involvement, again, it can be a feature of Lambert-Eaton syndrome, where the patient might have xerostomia, that is dry mouth or impotence, but there is no alteration of autonomic nervous system in myasthenia gravis, right? So this is a very beautiful table to differentiate between Lambert-Eaton syndrome and myasthenia gravis. Clear? So this is very important. So just going with the words, and more importantly with the incremental word, I think your answer has to be Lambert-Eaton syndrome. Clear? So this was a very beautiful question, I think, and I guess most of you must have marked it right as well. Okay, chalo. The next question, a patient presented with inability to open the mouth, right? So inability to open the mouth and muscle weakness. So inability to open the mouth and muscle weakness, and later on it was diagnosed as a case of botulism, right? So now the question was about the mechanism action of botulinum toxin. So again, this question, and this toxin actually acts somewhere around the neuromuscular junction, and this actually affects the SNAP protein, right? So there is dysfunction of the SNAP proteins, and you can see these SNAP proteins are actually helpful in the release of acetylcholine from the synaptic vesicles in the presynaptic area, right? So you can see these are the vesicles, and these black dots are actually the neurotransmitter, that is acetylcholine, and this is all presynaptic area, or you can say presynaptic knob. And these SNAP25, these are important proteins which are needed for rupture of these vesicles and the release of acetylcholine, that is the neurotransmitter, into the synaptic space, right? So the botulinum toxin actually interferes with these SNAP25 proteins, and therefore there is no release of acetylcholine from the presynaptic end. Clear? So this is in short about botulinum toxin action, right? So you can see these are the vesicles, and in these vesicles we have acetylcholine. Okay, so these vesicles, they cannot bind to the presynaptic membrane and they cannot rupture, so there is no release of acetylcholine, right? So it is not released. Clear? So even it's written here, toxin blocks release of acetylcholine from vesicles, and therefore the neuromuscular junction transmission is hampered. So this is botulinum toxin, right? The next question, I think it has been repeated numerous number of times. Most sensitive test for myasthenia gravis. I think the answer is, it's a repeat question, I guess. So answer is single fiber. So it is single fiber electromyography, right? So this is single fiber electromyography, which is the most sensitive test for myasthenia gravis. And we know that in myasthenia gravis there are antibodies against acetylcholine receptors. Clear? So there are antibodies, so we can also check these antibodies, but sensitive is single fiber EMG. So please remember. So this is the pathology actually. right? So this is the most sensitive test. Then there was one question from respiratory system, and here bronchoalveolar lavage specimen of a patient suffering from pneumonia was shown, and it was asked like what was the agent and what is the treatment, right? So this is bronchoalveolar lavage, right, of a patient of pneumonia. Now this was the image which was given in the exam, and based on this one has to identify like what organism was this and what treatment has to be initiated, right? So here like if you look properly, and I think one of the hint from the question was missing, like it would have made your word more easier, like if it would have given like a patient with HIV, right? If this word would have been given, it would have make your job lot more easier, but that was not there. So this is actually a staining of or a specimen of Pneumocystis carinii, right? And I think most of you must be knowing that for Pneumocystis carinii or Pneumocystis 0HE, we will give cotrimoxazole. Now, how to identify this as a smear of Pneumocystis 0HE? Now, what you can see here, you can see something like this, and in this you can see multiple dots. Right? So if you can see this kind of picture, which is actually the cyst of Pneumocystis 0HE and having the sporozoites in it, this is a classical picture of Pneumocystis 0HE, right? So the treatment has to be cotrimoxazole. So if you can look here again, the same picture, and so this is a cyst, okay, and within the cyst you can see there are nuclei, something like this, okay, or like this, okay. So this is how you can, especially in a case of bronchoalveolar lavage, if you see this kind of picture, think of Pneumocystis 0HE. Especially we discuss a lot about is that we discuss a lot about this, that it is commonly the agent of causative agent for pneumonia in a case of HIV/AIDS, and this is how actually the bronchoalveolar lavage or induced sputum specimen looks like, right? So please remember it. Again, this topic is extremely important. I think every time in one or another way you have a question from this section, right? So please read it carefully and in detail, right? So this is how it actually looks, the cyst of Pneumocystis 0HI. Then there was one question from abdomen, and it was about unconjugated hyperbilirubinemia. So it means the level of unconjugated bilirubin was increased, and to understand this you should have a basic idea about the Kussmaul. I think firstly you should look at the time frame with you, right? So if you can, personally I would suggest you, if you can go with 5 years PYQs at least, right? So please go with 5 years PYQs like NEET PG, INI-CET, UPSC, even FMGE. The more you study, it might help you more, right? So at this moment of time, I think it's better you go with PYQs and try to focus on 5 years at least. 3 years it will be a little less, I guess, right? But only if time permits, right? If you think that you are not able to do 5 years, then okay, you can be satisfied with 3 years, but try to, take 5 years at least, right? So that's for Kussmaul especially. Anyway, coming back to the question. Now here the question was about unconjugated excess bilirubin, right? So before that we should know like what actually is the mechanism of bilirubin metabolism, right? So we know that okay, welcome Kushagra. We know that like when the RBCs are broken down, or what you say, hemolysis, right? So what will happen? Hemoglobin is released. Now this hemoglobin contains two things, heme, right? So it will heme and globin. Now the globin is a protein, so it will go to protein pool, right? So it will go to protein pool. Fine, it is a protein, so it will move back to the protein pool, and this heme will break into biliverdin first, which will be converted into bilirubin. So we will get the bilirubin, and in between we have biliverdin as well. Now this bilirubin is produced, and this is as we all know, it is highly toxic, right? So it has to be conjugated. So it is taken up by albumin. So bilirubin plus albumin, and then it is brought to the liver for conjugation. Clear? And once conjugated bilirubin will be drained through the common bile duct, and it will go into the second part of duodenum through the common bile duct. Clear? So this is the usual mechanism of bilirubin metabolism. Now what happens if there is any pathology which is affecting up to this stage, right? So any pathology up to this stage, this all will result in increase unconjugated bilirubin, right? So increase in unconjugated. And if there is any pathology which is occurring at this is all conjugated, right? So increased conjugated, and this is increased unconjugated, right? So this is how we presume, like, what is unconjugated type of excess of bilirubin and what is conjugated type of excess of bilirubin, right? So if the question is about unconjugated, it means the question or the pathology is somewhere till the level of liver. So whenever we say unconjugated, there is possibility that there is excess of hemolysis, there is excess of production of bilirubin which is beyond the capacity of liver to conjugate. That is one possibility. Number two, there is some pathology in the liver itself where there is deficiency of certain enzymes which were needed for that normally produced bilirubin, right? In that way also there is excess of unconjugated. So with respect to these conditions, the best answer would come out to be the Gilbert syndrome. And what actually in Gilbert syndrome, there is decreased activity of an enzyme which is needed for conjugation, right? So UGT activity, or in simpler words we can remember it as gluconosyl transferase enzyme, right? So this is the enzyme which is affected here, and that's what it's causing less of conjugation of bilirubin, and therefore the level of unconjugated bilirubin will increase in the blood, right? So that is a basic about the pathology or the pathomechanism of Gilbert syndrome. So there is decreased UGT activity, and therefore there is less conjugation of bilirubin, so that unconjugated bilirubin will increase excessively in the body, right? So this is Gilbert syndrome, one of the examples of unconjugated excess of bilirubin. So with these words, I'd say a thank to all of you for just spending your valuable time with me, and I will share these PDF with all of you, and I'll request again, just drop me a message on my WhatsApp number, right? So this is my WhatsApp number. You can just drop me a message and I'll share the PDFs with you. right? So I hope all of you must have enjoyed the session. I have tried to simplify the things as much as possible, and I tried to discuss the concepts from a beginner's perspective, and I hope you should be able to remember these concepts for a longer period of time. So with these words, I thank all of you, and yes, not to forget, tomorrow 10:30 p.m. we will have surgery session, right? So surgery recall. So my approach is to take all the subjects in a very short span of time. So tomorrow I'll come prepared with surgery part. So I'll request all of you to just join me and encourage me. So see you for tomorrow. Bye bye. Good night. God bless.